This is a systematic review of automated sepsis alerts in the emergency department. I'm Matthew Hwang, a medical student at University of Illinois going into pediatrics, and our team includes Dr. Powell from Northwestern University and Dr. Bond of jump simulation at OSF in Peoria. We have no conflicts of interest to report. Automated alerts have become more popular with the widespread use of EHR systems. Electronic sepsis alert systems are based on simple rule sets, or more recently, complex algorithms. Sepsis alerts have shown mixed results in various settings. We believe more refined alert systems will produce improvements in both diagnostic accuracy and quality measures. Sepsis is typically defined as 2 or more SIRS criteria, which is described here with an infection source. This is an example of a simple rule set pulled from one of our included studies. You can see triage vital signs here, and if certain criteria are met, a sepsis alert will be triggered. And in contrast, we can see an algorithmic based alert here, and we can appreciate its complexity compared to the simple rule-based alerts. For our study, we systematically searched PubMed, Embase, the Cochrane Library, and CINAHL. Our inclusion criteria are shown below. We have adult patients in the ED diagnosed with sepsis and its variants, and an electronic system that alerts providers in near real time. We found 731 references, and when screened we found 20, and after a full text assessment, 10 studies met our inclusion criteria. We charted the characteristics of the different studies here, and of note, the definitions and the methods of alert, and treatment recommendations as well, have great variety between different studies. To summarize the characteristics, 8 of the studies assessed accuracy and 6 assessed outcomes. 2 studies had complex algorithm-based alerts, while 8 had simpler rule sets. All systems use different criteria to define sepsis, and all of them use SIRS as the base criteria. Here's a chart of the diagnostic accuracy, and here are quality measures and markers. Our diagnostic accuracy results are summarized below. Sensitivity ranged from 33 to 100%, specificity from 78 to 99%, PPV from 5.8 to 54%, and MPV was consistently high. Bonsall had nearly 100% sensitivity and specificity without any significant survival rate decreases. And interestingly, Austrian and Martin Rico had significant improvements in outcomes with modest accuracy. 2 independent reviewers assessed risk of bias and quality with the QuadS2 and GRADE rating systems. A few of the criteria are shown here. Considering prospective cohort methods, 6 of the studies were deemed to be relatively high quality and 4 were low quality. We found that process measures showed modest improvements. For high quality studies, there were significant improvements in time to first lactate and chest x-ray before admission. For low quality studies, there were significant improvements in lactate testing, antibiotics in 60 minutes, and mean time to antibiotics. Outcome measures that significantly improved were length of stay and vasopressor use based on 1 high quality study. Mortality was not shown to improve in rule-based studies and only improved in 1 low-quality algorithmic-based study. Overall, most of the study designs assessing impact were weak. There were also potential confounders, such as response teams or order set bundles. Sepsis alerts represent a challenging area to study with traditional randomized methods. Moving to a more rigorous study design requires both holding the alert constant and ethical approval for a non-alert or clinical gestalt arm. Operators of these sepsis alert systems can often tune the sensitivity to a desired value. Our limited evidence suggests that they can be tuned to a high sensitivity to detect sepsis. Evidence from both low and high quality studies showed some evidence for improved process of care markers, including time to antibiotics. However, no high quality study showed a difference in mortality, and only 1 high quality showed impacts on ICU length of stay and vasopressor use. Additionally, no studies addressed potential negative effects of alarms. In conclusion, our systematic review shows sepsis alerts may be tuned to high accuracy. These alerts have a potential for positive impact on care. However, more studies are needed, especially high-quality studies of newer complex algorithmic systems. In the future, success will likely be found in studies that use time series or perhaps cluster randomized rollout methods across healthcare systems. Here are our sources. Special thanks to Emily Johnson for helping build the search strategy. For more information, please contact me at this email address, and thank you for watching.